So I think we have been talking about this particular subject quite a long time. Uh, Probably I'm going to show more indications in this particular topic today. So this is the data which we can see that worldwide collaborative study, last data updated in 2019, that is just prior to the COVID, 18 centers across the world, 700 attempted cases. The success rate was quite significant. You can see that two-thirds of the patient, 67% of the patient had biventricular circulation. That is the only one point you should know, that still there is a lot of hope for the fetal cardiac intervention. The earlier data from Boston Children's Hospital and other anecdotal cases showed that it was only 1/3 to 33% towards biventricular repair. The recent European data, especially from Austria, which showed quite a significant number of fetal critical aortic stenosis or pulmonary atresia intact septum going to biventricular circulation. In our country, the biggest challenging aspect is we are dealing with two people, two patients, one mother and a second fetus with congenital heart disease. Only fetus needs treatment, mother is going to be innocent. The biggest question is whether it is going to harm to the mother. Actually, if you look at the data, there is less than 1% of population who underwent the intervention, fetal intervention, had some sort of problem. There's only one death reported so far in the all 700 cases. So that indicates it's fairly safe to the mother. The potential indications are aortic stenosis, balloon aortic valvotomy, pulmonary atresia intact septum or critical pulmonary stenosis, possibly a balloon pulmonary valvotomy, and restrictive foramina uveal, stenting of IAS, some of the arrhythmias, now newer indications which we what Vikas told, that maternal immune mediated SLA and all we can treat it to some extent. So you all know that if you don't treat these cases, critical AS or critical PS, eventually they will go to hypoplastic left heart syndrome or hypoplastic right heart syndrome. All these are due to secondary hemodynamic abnormality rather than primary genetic abnormality of the ventricles. It's actually, to begin with, a lesion, then hemodynamic alteration and hypoplasia are the sequelae. You look at this left ventricle, which is ballooned out, dilated, dysfunctional, and if you don't do these kind of cases in the early gestation, they eventually will go to hypoplastic left heart syndrome. This is the first data in 1997 by Jam Simpson group in UK showed that the natural history of aortic stenosis in fetus, more than 60% will eventually progress to hypoplastic left heart syndrome. So similarly, pulmonary atresia intact septum, you can see a case here. This the right ventricle is too small. There is an antegrade flow here. They will go to hypoplastic left heart syndrome, either 1.5 ventricular repair or univentricular path once they deliver. So these are the potential dangers of in vitro. In case of HLHS, where there is an Norwood program, it's mandatory to open up the intrathecal septum. So these are all we discussed, that the case selection, all those things you can actually read in the literature. I'm not going to emphasize much on this selection criteria because it's freely available, and we have also published in a couple of chapters and other things. But important aspect is procuring the equipment and preparing the team and administration and counseling the family is going to be important. These are the some of the needles which we need to procure: Sheba needle, M3 coaxial or Hawkins Akin needle. The balloons which we procured, Relaces company was preparing, now they stopped because we were using freely from the company. And this is how we prepare the balloon and put the system which is described, two markers, and how much of balloon should come out of the
Stick
needle.
both together. Stick it.
This video is freely available in the YouTube. You all can actually see if somebody wants to see this or give it to the patient from the give intramuscular injection, anesthesia, then make the baby stable, then you give maternal anesthesia are the key points for the success. Otherwise, you are going to have serious problem because of once you give maternal anesthesia, baby continues to move for some time, then you will not get the desirable position for the valvotomy. So that's how you actually take the LV puncture and then introduce the coaxial system of guide wire balloon assembly and inflate the balloon under echocardiograph ultrasonogram guidance in the operation theater. Now lot of people they are doing in the OPD basis in North America. The Boston children also they started doing, and then see the success of. So this is one case of a twin pregnancy where you can see here three patients, two patients that the mother and one baby are normal, another baby is having a severe critical aortic stenosis. These are the steps. First, after giving intramuscular injection, you puncture the left ventricle. When the left ventricular outflow tract in coaxial, you can see that puncturing of the left ventricle. Then introduce the wire balloon assembly across the left ventricular outflow tract. Your needle is just below the LVOT, and you can see this is the balloon which is being inflated here across the aortic valve. Postnatal, you have to see that whether there is any diastolic dysfunction. Fetal aortic valvotomy is not a standalone procedure. Most of the babies they need second procedure after the birth. These are the 100 cases of Boston. Again, they analyzed and proved that 43% of the fetus will have good outcome by ventricular repair. So this is another pulmonary atresia, intact septum, which I have shown you the case. The right ventricle is too small. All criteria are fulfilled for the procedure. 1200 grammer baby. We had to give again taken the baby for the procedure. You can see the intramuscular injection being given, and this is the entry of the right ventricle. Right ventricle is outflow tract is more anteriorly, so that's why you have to put the needle little bit angulation and then perforate the pulmonary valve. You can see the pulmonary valve is being perforated here with the needle, and subsequently balloon is being inflated here. You can see that, and then we will remove entire assembly, balloon, guide wire, and needle. Otherwise, you will get avulsion of the balloon. That is not a good sign, good thing. So you will have pulmonary regurgitation almost always. So postnatally, these babies really do well, pulmonary atresia. So whatever cases we have done, they have biventricular circulation at this point of time in pulmonary atresia intact septum. This is my friend Adam sent this picture of intratal septal stenting in case of HLHS. You can see that the stent being deployed across the intratal septum here. So now recent indications, we see a lot of isolated pericardial effusions that turns to be chylous. We aspirate them. We have done close to 5 cases of this, and also you can see that, and also fetal intraperitoneal gamma globulin. My colleague Dr. Shweta actually suggested that with the concept came from North American intravenous gamma globulin and Japanese intraperitoneal gamma globulin for CMV virus. So we clubbed both together and we started giving to the intraperitoneal gamma globulin. You can see that we give slowly. This is the initial flush. Then surprising thing is all these babies are going to have the normal ventricular function. This is the ventricular function before. You can see ventricular function after, and high drops are completely resolved in 1 to 2 weeks at time. This is our data, the last data updated. But I want to tell that close to 35 patients were counseled for the procedure, and you have lesser than 50% only will show for the fetal intervention. So I will skip off some of these things. So why fetal intervention program is not well developed in our country? Because of a diversified population, culture, social issues. we are all very busy, lack of team approach, training, financial aspects, medical legal issues. As an average pediatric cardiologist in our country, we are seeing OPD, doing some interventional procedures and conducting outreach camps. That's why this branch is somewhat neglected in the past. Now, reasonably, it is coming up because a lot of youngsters, they are taking it. You need to have a Norwood program, local creation of local awareness, timely referral, and do natural history studies, imaging, and educate the family. To summarize, the Indian scenario is essentially influenced by the social and cultural issues of the society. The team approach, appropriate referral influences the outcome significantly. Technical challenges are many, and we'll have a steep learning curve. These are all babies. Aortic stenosis. This child is now 7 years since we did part one and other cases here. Thank you very much for your comment.
Thank you, Dr. Nageshwara, for that excellent talk. And thanks for sharing your expertise and experience in this field. For want of time, we can take one question for this talk, then we can move ahead with the next talk. Yes, yeah. You can.
While doing this balloon dilatation of the aortic valve, critical aortic stenosis, how difficult is passing this valve? Like
How
difficult is passing the wire once you puncture it, the LV, because it will collapse.
The most difficult part is positioning of the fetus, and the left ventricular entry. If you enter the left ventricle into outflow tract, wire will go automatically. You don't need to do any majoration.
Isn't it like that when you puncture the LVs under a lot of pressure, it collapses immediately?
Yes.
And then
it collapses, then you have to wait for a while. It will refill immediately. It collapses because of your pressure. That's why sometimes you have to have the counter push from the opposite side.
Excellent presentation, sir. Have you come across aortic regurgitation after BAV?
Aortic regurgitation is inevitable in almost all cases. It will be mild to moderate, even sometimes maybe severe, we have not seen, but most of the cases they improve before birth. You don't see aortic regurgitation after birth. There will be aortic regurgitation because here you are not perforating the valve. The wire is going through the orifice which is narrowed. Whereas pulmonary artery intact septum, you are perforating the valve. The mechanisms are two different. Thank you.
Hi, Nagar sir. Lovely to see you after so many years. Just one question. What injections you are giving intramuscularly to the baby?
So we give fentanyl and
Okay.
vecurarium.
Right.
The dosages are written which is available.
Right. And nothing to the mother?
Mother, initially we don't give. Local, we give local. But we are using 21G needle for intramuscular injection.
Okay.
So that itself is too small. So sometimes we don't even give local anesthesia. Once we give that, baby will be stabilized, then shift and give general anesthesia. We give general anesthesia to mother.
Right. Just, it will take 20 seconds, don't worry. Can it be given intravenously to the mother to sedate the baby using very common, sedatives?
It takes a long time to
That's
cross the placenta. It takes some time. By the
That's
time
okay.
your movements may not be.
Okay, fine. Thank you.
Thank you, sir. Sir, next I'll call upon Dr. Usha Madam to give her deliberation on fetal echo in community practice, practicability and the impacts of it. Selected for the fetal quiz. So after the next deliberation by Dr. Munish Tomar, Madam, we can start the fetal quiz.
Good afternoon, everyone. My talk is a social talk. There is not much scientific information. It's a time for little pondering and introspection. So just relax and see if there are any solutions to the problems I pose. So what is an idea? The patient was a receptionist at one of my friend's clinic. She was ophthalmologist. She was referred to us for fetal echo, and we did a diagnosis of TGA with intact septum at 26 weeks of gestation. So I work in a public hospital where we have a long waiting list of at least 3 months when the baby has to be posted for surgery. So we referred antenatally, and the child got a date for surgery postnatally around 2 weeks of life. Baby was brought to our hospital within 2 hours of birth. Child required Prostin, and it was operated on day 4 of life and discharged by day 10. So this is how we felt. So this is what we expect from all our fetal echo patients. So what are the expected community effects of a fetal echo? You would want to diagnose all critical CHDs, create awareness, preparedness among the pediatrician, gynecologist, pediatric cardiologist, or the surgeon and the family, so that you can reduce the morbidity, you can reduce mortality, reduce the financial burden both for the family as well as for the system, reduce the cost of care because you're operating on a stable neonate without any previous comorbidities. You're not treating a moribund child, but a stable child. You would like to diagnose complex heart diseases and inform the family if palliative care is the only option, and treat some of the lesions antenatally. So these are the expected community effects of fetal echo. But is this actually happening? And like I said, you would at least you would avoid seeing patients with Eisenmenger syndrome, hypoplastic artery and cut off, and what like malnutrition, neurocognitive effects of prolonged cyanosis and all. So I would just like to take 3 cases, walk through what happened to them and how this whether we are getting the expected benefits in the community. First one was a tricuspid atresia hypoplastic RV with pulmonary stenosis and normally related great arteries. She was a primi gravida diagnosed at 28 weeks of gestation. So they came for fetal echo. We made this diagnosis. Parents were counseled in detail regarding palliative care, multiple surgeries, and were advised to come within 1 week of birth. Second case was a gravida 2 paravan living 1 at 24 weeks of gestation, diagnosed to have a large malaligned VST. First baby was operated for VST and was doing well. So parents decided to go ahead with the pregnancy and get the second child operated too. That case was a diagnosis of a TGA with intact septum in a primi gravida with 28 weeks of gestation. They were referred from a town called Shimoga, which is around 300 kilometers from Bangalore. So the first child with tricuspid atresia, this child, in spite of detailed counseling, finally visited us at 8 months of postnatal life. Child was brought with history of fever, cough, and coryza. Saturation was 29%. Child came on a Deepavali night. So the second child with a large VST, they came to hospital exactly 1 week after delivery. The echo findings were confirmed. Like I said, we gave a date for surgery. This was a VST. We planned to operate at 2 to 3 months of life, and they were advised to come at the same time. The TGA intact septum, she was counseled regarding delivery within 24 hours of birth, requirement of NICU care with probable prostaglandin, and surgery at 2 weeks of life. So this tricuspid atresia, who was extremely sick, acidotic and hypoxic, child was intubated, referred to surgeons. Child underwent an emergency BD Glenn. Child had some degree of LRTI, which had made it sick. So there was a prolonged ventilation of 2 to 3 weeks. Surgeons were very upset with us, calling them on a Deepavali night for an emergency surgery. And child had a lot of post-operative issues. Large malaligned VST, though they were advised to come and given a date for surgery, they came at 8 months of life. For some reason, which is very unusual, this child had a saturation of 70%. VST had become complete right to left, and the child was inoperable. The patient with the TGA, she's from 300 kilometers from Bangalore. They cannot deliver at Bangalore. They don't have any social support. If they deliver in Shimoga, we have to transport a sick neonate, maybe on Prostin also. How practically feasible is it? Will it add to the mortality and morbidity of the child? Where is the fault? We have done our job. We have made the diagnosis. We have patients, but still we are not able to get the desired outcomes. So where does the fault lie in the system? Is it a better communication between treating doctors? Maybe the tricuspid atresia child, if we had spoken to the local pediatrician, the gynecologist, ensure that they also participate in counseling the patients, make sure they are referred on time, maybe we would not have had such a sick child. What is the level of understanding of the patients? Is it a system failure where we have not recalled the patients? We don't have a system of calling back the patients if they don't attend on their follow-up dates. We have a large burden of patients beyond the capacity of treating. We cannot treat more than 50 to 60 congenital heart surgeries per month. It reflects in the social patients as well as lack of adequate centers providing pediatric cardiac care. So making an accurate diagnosis on fetal echo and detailed counseling doesn't have 66 million and 11 lakhs birth, and even if you assume 0.5% CHD, 5,700 will be critical CHD. We have maximum 4 centers and we can operate only 2,500 cases. So what happens to all the remaining numbers? Let's assume that at least 50% are diagnosed and they are referred for fetal echo. Is it possible for us to do so many fetal echoes? We will be swarmed by locusts and we would want to run away. So daily routine at our hospitals, we have at least 5 echoes per day and we can't dedicate more than 1 hour. Most of the times, 30 to 40% are for echogenic focus. So how are we spending our limited resources? So in last 18 months, we have done 650 fetal echoes, about 100 were abnormal and 30% were referred after 24 weeks of gestation. So again, there is a failure of the system, and 25% or 155 echoes we did for intracardiac echogenic focus. And we are doing ICMR study where we are collecting data of infants operated. So we had 269 children operated in last 18 months and only 15% were diagnosed antenatally, though more than 50% had complex heart diseases. There is a gross difference between expectation and reality. So we are ill-equipped to diagnose antenatally all CHDs. And in spite of multiple anomaly scans, we are not picking up CHDs. And suppose we diagnose all of them, we cannot handle all of them postnatally. And even if the diagnosis is done, the complete benefit is not being translated to them. Are there any flip sides to fetal echo? So I had a father who visited me in the OPD. They had got a first trimester scan report from outside. He wanted to know if his baby is going to be 100% perfect. Otherwise, he would want to terminate the child. The first trimester scan report said trivial tricuspid regurgitation. And he wanted for him that the baby will be perfectly normal. I've had parents coming to me asking for termination, for echogenic focus, for a VSD, for an ARSA, because they were told that baby will choke and die as soon as it is born. For a persistent LSVC, as they were advised scan every 2 weeks for coaptation. A C-section is recommended, emergency C-section for a suspicion of coaptation. So these are the other effects of fetal echo, which we are seeing in the metro cities where everyone gets a detailed fetal echo. So the solutions to reach our goal, increasing the awareness among primary care doctors, including pediatricians, gynecologists, and radiologists through a part of curriculum, frequent CMEs, and training program. We need to have a very strong network of communication between various specialties. Literacy rate of the patients matter a lot, especially female literacy and women empowerment. Robust network of primary and secondary level healthcare, efficient emergency transport system, and telemedicine can provide some answers to the problem. Increase in infrastructure multiple fold, and uniform distribution of healthcare facilities and coordinated planning and execution by physicians and policymakers is important. So Kerala model, I thought Dr. Balu will give a talk. Unfortunately, we didn't have that. It is a perfect example where all this has worked. Finally, in conclusion, to have a successful fetal echo program which gives benefit to the community, you would want an efficient primary and secondary health system with robust and widespread pediatric cardiac care, with a strong network between the various specialities, and the literacy and socio-economic status also matters to a significant extent. So detailed counseling, risk, single versus biventricle, multiple stage therapy, cost, everything is important, but that's not the end. And though we would like to say I'm so proud of myself, but there are further problems which needs to be addressed. Thank you.